Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Dr. Schwartz. In today's episode, we discuss the fundamentals of specialized agents for treatment-experienced people living with HIV. For more information or to follow along with the slides, visit the show notes for this episode. Now let's get started.
My name is Georg Behrens, and I'm Professor of Immunology and a Senior Consultant in the Department of Rheumatology and Immunology at Hannover Medical School in Hannover, Germany. This is part 2 of a 4-part program, HIV Care for Treatment-Experienced People, Optimizing ART and Improving Outcomes. And of course, I invite you to view the other medical minutes and the accompanying slide sets for this program on the Clinical Care Options website. This program is supported by an educational grant from BEEF. So if we look and treat patients which have multiple pre-treatments and are heavily treatment experienced, there is 2 major conditions that we need to separate and to deal with. Either we've got a situation of a virological failure, or if patients are virological suppressed but have multiple pre-treatments, we need to consider any change of treatment. So in a virological failure condition, clearly the primary goal is to reestablish virological suppression and control. And the second goal, of course, is to allow and enable immune recovery and to get people out of a risky area of low CD4 counts. If we switch for whatever reason, for instance, to mitigate adverse events, drug-drug interactions, or other issues, we always need to consider that we need to maintain virus suppression without limiting any further future options. We need to consider the pre-treatment history in these patients. So how do we do this? Key point that we need to avoid is to just add a single drug to a failing regimen. We should always avoid doing this. Whenever we react and respond to a failing regimen, we should aim for adding 2 fully active antiretrovirals. And at least one, but both of them should have a high resistance barrier. And if at all possible, we should always aim for including 3 fully active antiretrovirals, if none of them has a high resistance barrier. And another key point to consider is whenever possible, particularly in heavily treatment experienced patients, to use and consider drugs with novel mechanisms of actions, because that enables us to have a fully antiviral activity established. I said before, various guidelines and also DHHS guidelines highlight the key treatment goal, maintain virological suppression. Before we change anything in a treatment regimen that's still active and efficient, we need in people with lots of pre-treatment to look for the past treatment-associated toxicity and intolerances, and very important to have an overview about all resistant test results, because everything that has happened in the past in terms of resistance mutation development can be relevant for the future. It's not just the last resistance test, but it's every resistance test. Every mutation that ever occurred has the potential to cause damage to future treatments. In terms of selecting novel drugs or drugs with novel actions, an attachment inhibitor can interfere with GP120 on HIV, on the virus, and prevent the interaction to CD4. It can also be a post-attachment inhibitor, which prevents the binding to the co-receptor on the host cell. And the capsid inhibitor is yet another function and mode of action. It interferes on various levels and prevents the virus from entering the nucleus and prevents new viral productions by interfering with viral reassembly. So fostemsavir is a prodrug of tenofovir and one of the key drugs for people with heavy or various pre-treatments. And this falls into the group of the attachment inhibitors. It's a prodrug and it inhibits GP120 from binding to CD4. So what are the data supporting the use of these drugs? In a large study, the BRIGHT study, fostemsavir was implemented in regimens and patients recruited for this trial, which had various pre-treatments and multiple resistance mutations. There were only 1 to 2 remaining antiretroviral classes available, and it was otherwise not possible to construct a viable regimen with the remaining agents. And patients were randomized to either receive fostemsavir twice daily, remaining on the failing regimens for a short time, just 8 days, or receiving placebo. This phase is kept very short in order to show what is the single drug fostemsavir able to achieve in terms of viral reduction. We see already that the viral load was reduced by about 0.8 logs during this early treatment phase. And then there was a follow-up of an open label treatment with an optimized backbone where more active drugs were added. There was also a non-randomized cohort, which even had more advanced and more complex resistance mutations in the patients that were included here. So how was the pre-treatment and the treatment experience in these cohorts? Many of the other treatment classes and drug classes had been used before and had only limited options. But despite all these limitations, that fostemsavir, together with the optimized backbone, enabled in about 50% and even for a long time, a continuous full virus suppression, as shown here as a proportion of patients with a viral load of less than 40 copies. So that was really remarkable and very important. But of course, in these patients, we not only look for viral load, but also for CD4 cell counts. And interestingly, there was a very good increase in CD4 cell counts, and that was more or less independent of the number of fully active antiretrovirals in the baseline optimized backbone, which means fostemsavir was a major contributor to the overall also immune response. Overall, so you see very good CD4 cell recovery and immune reconstitution, even people with very advanced immunodeficiency at the beginning of this switch to new treatment. In terms of side effects and adverse events, most drug-related adverse events are related to either nausea, diarrhea, and some other gastrointestinal side effects. Of course, these patients have a slightly higher rate of also treatment related adverse events and also serious adverse events, which are not necessarily driven by the treatment, but by their immunodeficiency and their risk to develop opportunistic diseases and complications. So overall, fostemsavir was very well tolerated, even in this population of heavily pre-treatment, with heavy pre-treatment and virological failures in the history. It's important to consider that fostemsavir has some drug interactions, hepatitis C, virus, antiviral drugs, oral contraceptives, and also the interaction with statins can be relevant, where we need to be a bit more careful with the dosing of some of these statins as co-medications. And probably most important to consider is also that there is no drug-drug interaction with any of the other antivirals, retrovirals that we use, which is important and gives us a good chance to consider all other medication that we want to use in the optimized backbone. There is some evidence from studies that have shown that circulating proteins from the virus, like GP120, induces some unfavorable effects in the immune system and leads to activation of the immune system and disturbed cell function. And it may be that the use of drugs like fostemsavir that neutralizes also free proteins circulating in the blood is a beneficial effect and could also be a contributor to the good CD4 immune reconstitution. There is even recent data that have shown that people that even under different treatments achieve no circulating GP120 in their plasma, that they have better CD4 cell counts, less inflammatory markers increased, and a bit more favorable and stable immune system. And this might be a reason to consider fostemsavir also in people with advanced disease and virological failure. What about ivelisumab, which is a monoclonal antibody and also an attachment inhibitor? Ivelisumab is a post-attachment inhibitor, and it does not inhibit GP120 from binding to CD4, but it interferes with this complex, which then inhibits the binding to the host co-receptor, namely here CCR5. And as said, this is a monoclonal antibody, and it's, of course, then administered differently to fostemsavir, which was an oral medication. Ivelisumab was also tested and explored in heavily treatment-experienced adults with limited treatment options and multi-drug resistance. They received a stable AIT before, but had a detectable viral load of above 1,000 copies, which means virological failure. And these patients received an infusion with ivelisumab on day 7 and day 0. And in this early phase, we looked for the decline of viral load that is achieved by this monoclonal antibody only. After 14 days, then ivelisumab treatment was intensified by adding the optimized background regimen, and that was then continued. So this early phase, again, is just a phase where we look for what can the new drug achieve in terms of viral suppression. And we want to keep this time as short as possible to prevent any resistance mutation, because this is a functional monotherapy. There was a good decrease in the HIV RNA with a decrease of more than half of the log, and that was maintained up to week 25. Probably more interesting is the rate of people that achieved the viral suppression, less than 50 copy, up to 50 to 60% in the long term with this regimen achieved a full virological suppression as a response to the virological failure we've seen before. The CD4 cell increase with this combination was slightly less as compared to what we've seen before, on average 42 cell. That could be because of the selection of patients. And again, what we could see is that the genotypic susceptibility score of the optimized backbone regimen was not strongly related and correlated to the immune reconstitution, again arguing that ivelisumab as the new compound, also dropping the viral load, is an important contributor to the immune reconstitution. Again, adverse events related to ivelisumab relatively low percentages, with 18% sometimes patients developed a mild rash in regard or in response to this infusion of the monoclonal antibody, which in the long term has to be given every 2 weeks. Rarely these side effects led to withdrawal and interruption of the treatment. And again, of course, also patients advanced either to AIDS or AIDS-related diseases and other complications, just reflecting how sick they also were when they were included into the trial and required to respond to the biological treatment failure. So a last very important component for heavily treatment experienced patients is lenacapavir. Lenacapavir is a capsid inhibitor, not an entry inhibitor. It does not inhibit entry, but it does inhibit capsid entry into the nucleus, the uncoating, and the assembly. So it interferes at different stages of the replication cycle and probably has some synergistic activities through these different modes of action. Also, lenacapavir was studied in people with multi-drug resistant HIV. The Capella study was a phase 2/3 trial and consisted also of different cohorts. Patients had detectable viral load of about 400 copies, resistance to at least 2 agents from 3 to 4 main antiretroviral classes, and limit treatment options to construct an effective treatment. And they were randomized into 2 different arms. And also here we saw a smaller non-randomized cohort. The randomized, again, received lenacapavir as an oral monotherapy to start with. But the aim of the study was to use lenacapavir, as we know it also from prevention trials now, given as sub-Q injection every 6 months, combined with the optimized backbone regimen. So again, this oral lead-in phase of about 14 days was for tolerability because of this long half-life time, and to see what is the drug in an isolated administration together with a failing regimen backbone and able to achieve in terms of viral suppression. Lenacapavir did very well. Only 2 out of 12 in the placebo had a response, and there was a good response in 21 of the 24 that were in these early phases. It's not only more than half along, as we've seen before with the other medications also. It was after 15 days, about 2 log decline. So very good antiviral activity of this drug. And then in the follow-up, the optimized regimen, of course, was added in this treatment. And that is the reason why the drug and the response here was maintained over time. At week 156, we're still 61.4% at a fully suppressed viral replication. Very few discontinuation, but there are few lost to follow up. And most patients receive their injections also in the long term within a 14-day schedule. And also in terms of immune reconstitution, which is an important surrogate and readout and outcome in this study, did you see that patients that were randomized to receive the lenacapavir a good immune reconstitution? Also, it seems like continuous increase over time over this long follow-up of over 156 weeks. And the proportion of people achieving CD4 counts above 200, which is an important region where we clearly reduce the risk for opportunistic infection, was constantly increasing, just illustrating how important such a combination, if used in the right context, can get these people out of a risky low CD4 region. in terms of side effects and adverse events, treatment, emerging adverse events, very often diarrhea, nausea. There were a few reports on nodules at the site of the injection, but no specific pattern that was described here. Again, the rate of serious adverse events always slightly higher as compared to people that have not so advanced disease, have better immune cells and CD4 cell counts to start with. And we see here that serious adverse events occur slightly more often as we use this to see this in other charts. Relevant for lenacapavir is also to consider, again, some drug interactions that lenacapavir interferes with the cytochrome 3A system. It also interferes with the GTA system, GTG1A, and with the transport system P, the P glycoprotein, where it's mainly a substrate. So I think looking back at these 3 different options of new drugs in different classes, it's very important to consider using these drugs at a timely fashion. We should never wait until all treatment options are used up. You've seen that also these new drugs, which have strong antiviral activity, only perform in the concept of good activity coming from the optimized backbone treatment. For highly treatment experienced persons with HIV, formation of a new regimen after biological failure may be very challenging, very much driven by the limited treatment options. And as we've seen also, for those that just want to switch, we need to consider various arguments. The opportunity to use the new drugs in novel classes increases the ability to form these regimens with 2 fully active compounds, and the availability of multiple new agents allow us to tailor the use of each agent to the patient, taking into account the patient's preferences and characteristics.
Thank you, Dr. Behrens, and many thanks to our listeners for joining us. To view the full program on HIV care for treatment-experienced people, click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease podcast on your favorite player. Thank you, and we'll see you on the next podcast soon.